Hello, everyone. Good evening or good morning, depending on where you are. My name is Frank from Wisonic Medical. You are so welcome to attend our webinar, Wisonic Global Webinar Dandelion Program, with mission to widely popularize the point-of-care ultrasound utilization in medical practice, such as anesthesiology, pain management, MSK, intensive care, and emergency medicine, by in cooperation with different experts across the globe, to do online webinars or in-person workshops, trainings. So far, we have completed over 700 webinars nationally and internationally since 2020, attracted over 180,000 doctors attended, received over 3.2 million reviews and comments. This time, we are honored to have invited 8 renowned MSK experts in the United States to participate in our program, MSK Ultrasound Webinar Series. In these 2 months, they will present a comprehensive webinar series about musculoskeletal, including lecture topics on orthobiologics therapies and ultrasound utilization in MSK practice, covering common body parts like shoulder, elbow, hand, wrist, hip, foot, ankle, and knee. Here, I would like to express our most gratitude to these 8 respectable experts. Thank you. So today is the 6th webinar of our MSK Ultrasound Webinar Series program. Let me show you my screen to introduce the detail. Today we invited Dr. George Chen as a speaker and Mark Kessler as a moderator to lecture with topic on ultrasound in MSK practice, foot, ankle. Mark Kessler has abundant experience in MSK and ultrasound. He started MSK and the cardiac diagnostic ultrasound profession since 2008, became ultrasound consultant since 2012, and the MSK instructor since 2014. He is a member of several famous societies in the US, like American Registry for Diagnostic Medical Sonography Society and the Society of Diagnostic Medical Sonography. Moreover, he is the regular moderator for all of the 7 webinars in this MSK Ultrasound webinar series. So Mark, could you please introduce today's speaker, Dr. George Chen?
Welcome everybody to a great another session in MSK Ultrasound. Tonight I want to greatly introduce Dr. George Chen. I've known him personally for quite a few years. Wonderful physician, really knows his ultrasound and regenerative medicine. So his background kind of entails he's currently the director of pain management at the Ventura County Medical Center. He's also the director of physical medicine and rehab, also at the Ventura County Medical Center. He's also the director of GCC Institute, which entails regenerative medicine and ultrasound. He's also the director of medical education at Advanced Regenerative Medicine Institute. He got his doctorate in osteopathy from Western University, did his internship at Advocate Illinois Masonic Medical Center. Then he did his residency at Rehabilitation Institute of Chicago and did his pain medicine fellowship at the world famous Cleveland Clinic. Dr. Chen has vast experience in regenerative medicine and MSK ultrasound. He has numerous honors and awards and has been in many leadership roles. He has written many journal reviews and publications. Now let me give it up to Dr. Chen as he will talk about the foot and ankle ultrasound. Doctor, it's all yours.
Thank you so much, Mark and Frank. It's such an honor to again be a part of the Wisonic team. Let me just pull up my slides, and I forget, how do I share my screen? Frank?
There's the menu on the bottom of the Zoom.
Okay, there we go. Okay. Is that working now?
Yes, it's working.
Okay.
Yes.
Please.
All right. So I'm going to get started.
Okay.
Is that working?
Yes. That's good.
All right. So I have a lot of slides, and I'm going to kind of go through this really quickly because it's difficult to, a lot of the participants typically are very advanced. The foot and ankle, admittedly, is probably the most advanced, or I shouldn't say advanced, the most detailed and complicated portion, I think, for MSK anatomy. But we're going to do our best to really highlight some of the big topics that people may be familiar with and dive into some of the more common things that you might treat from an MSK perspective. Okay, and thank you so much, Mark, for the generous introduction. This is kind of some of the roles that I do. I want to kind of talk about some of the tissue texture, the tissues that we're going to be talking about. Just to give people a basic review, we're going to be, because these are the things we're going to be talking about, really, especially in the foot and ankle. We're going to talk a lot about the tendons and the ligaments and the cartilage of the bone, et cetera. And the tendon is really just connective tissue. It's made of collagen fibrils, and you have dense, regular, and irregular tissue. Regular tissue, this is the tendon itself, right? When we talk about connecting from a muscle to a bone, you have these parallel collagen fibers, and they resist stress, typically in the most part in one orientation. You can think of something like the Achilles tendon. We don't think of it so much as tendon tissue, but we do have irregular collagen fibers, and you can think of this in things such as your skin. That's going to have to resist stress in multiple vectors. And so you can imagine your skin is going to get compressed, it's going to get stretched. And so it sort of has more of a complex woven pattern so that it can absorb that kind of stress. So when we take tendon tissue and we blow it up on our microscope, you can see that there's this normal tendon on the top left image. Can you guys see like my little arrowhead right here? I'm not sure if you can see that, but anyways, you can see the normal. Okay, thank you. So you have this normal tendon fibrils, and they all run essentially parallel to each other, right? When you start to develop tendinopathy on this bottom left image, you'll notice that you lose that regular pattern, and you start to get this irregularity. You can get little voids in there. And this bottom right image, what you have is that you see that you lose a lot of that. You start to get tears into it, and then you get this neovascularity, and that's the body actually trying to heal itself. The tendons were generally always considered avascular. They're not truly avascular. There is blood supply within the tendon between the collagen fibrils or the bundles. But anyway, when you get this sort of dense blood vessel neovascularity going into it, that's really to help heal the tissue. So what does it look like under ultrasound? In long axis, we have this bottom left image. This is the Achilles tendon in long axis. You notice you have these fibular bands. Again, they're all sort of compact. It's the same image that goes, with these fibers uniformly in the same orientation. As many of you know, that one of the first things that you see when you develop tendinopathy is that you have thickening of the tendon. You have lost that normal fibular architecture, and that's what this image is on the middle right here. You see sort of in this region right here, you have this thickening of that Achilles tendon. And this is what it looks like under short axis when it looks normal. Again, when the tendon's abnormal, you can have lost that fibular structure, you get thickening, you can get calcifications, neovascularity they can see on power Doppler, you have tears, etc. So that's an image of what neovascularity would look like. Again, that's the Achilles tendon. You notice there's that thickening in that middle portion of it. And this, you don't actually see this in truly acute injuries typically. I think it could mean different things in acute injury, but if you're truly talking about having neovascularity grow into it, it could take a little bit of time. Anyhow, let's move on to ligaments. Ligaments are dense fibrous bands, and they connect bone to bone. And so a lot of times these are going to be injured in overstretching injuries at the end range of motion for that said joint. So sort of the same idea, hyperechoic fibular bands. A lot of times they're going to be tightly adherent to the bone, overlying other things, overlying the bone, overlying menisci, et cetera. And you're going to identify them really based off of, they're typically going to be named by the two bones or so that they connect, or if they're connecting other structures. Okay. As a comparison, this is an ACL on MRI, and you can kind of get the same concept. So the ACL is a ligament, and you notice over here on the left-hand side, this is intact. And again, you have these tight, compact fibular bands, and this is a fully ruptured ACL on the right side. Okay, quickly talk about bone. So it's hyperechoic. You can't see beyond it. For the most part, the bone, especially if it's articular bone, should have smooth contour with a anechoic articular cartilage ridge over it. If it's abnormal, if you have abnormal morphology to it, it could be a sign of overuse injuries, et cetera, or development of arthropathy. And ultrasound, I think, is actually a fantastic tool for looking for some of these, for screening for superficial coracoid disruptions. I've certainly caught fractures this way that may or may not actually be missed on X-ray, depending on if they get the right view. This is the end of a chicken drumstick, and it's analogous to the cartilage that you have in your knee, or really any over any articular surface. It's this pearly iridescent cartilage, and we can visualize this under ultrasound, and it's going to be this anechoic rim overlying that bone. So let's talk about the ankle. And a lot of people get really intimidated when they talk about the ankle. We're going to break it up like most people do. They break it up really into the anterior, the lateral, medial, and the posterior compartments. And then we talk about the foot separately, which also can be anterior, medial, lateral, plantar aspect, dorsal aspect, etc. But most of the injuries that you're going to have related to the ankle are going to be related to this inversion and eversion injury, and they're going to injure the corresponding ligaments and tendons. Now, I've broken this talk up talking about mostly focusing on just MSK. So it's going to be tendons and ligaments because I already have like over 60 slides here. Okay. I'm not going to belabor this, and we don't have time to go over this, but it's always good to go back and review the bony anatomy. It can get quite complex in the foot. There's a lot of articulations in the foot, and these bones, in fact, for instance, many of these bones don't actually even have muscle or tendons attached to them. And so their only contacts are other ligaments or the other bones that help give it stability. I think it's a good idea to review this at some point at your leisure. So let's talk about the ankle. We'll start talking about the ankle, and we'll start talking about it in the front. So there's multiple tendons in the front. These help you lift up your toes. The predominant one that we're start off from the medial portion is the tibialis anterior. Then we have the EHL and the extensor digitorum longus. Be aware, if you are doing interventions in this area, there is a primary artery that runs over the dorsum of the foot, the dorsalis pedis. Just something you want to be aware of and be looking for when you're doing interventions here. So the anterior tibial-talar joint, you notice a few things here in this image. These are not my images, but you have the tibia there, and you have the talus. The talus is a complex bone. It's actually fun fact, it's the bone that has the most surface area for articular cartilage in the entire body. But here's the dome of the talus. They also call it the head, but this is the dome for it. And this is the tibial-talar joint. We have a fat pad in the anterior recess, and we have tendons that run over. It could be the tibialis anterior, possibly in this area, depending on where you're at. But it's also one of the bones in the body that actually has no muscles or tendons attached to it. Okay, so what does it look like when we peel this away? In this top right image, we have the tibia, we have the talar dome, and you see you have tendons running over it, and you have the articular cartilage running right over that, and you have this joint space with this fat pad. And so that is something that you should be aware of. If you can develop an effusion here that can push away that fat pad, that's this bottom right image here. And if you see a pocket of fluid there, it's just a suggestion of pathology, because normally you shouldn't have fluid there at all, or if anything, just a trace amount. Now, if you are going to do interventions in this area, you can come at it from that approach where you're just essentially kind of going between the tendons and injecting. Or if you want to inject, though, another way to get into the tibial-talar joint is actually to go underneath the tendons, and you can come from a medial approach. You can identify the tibialis anterior tendon, the EHL, and you can come from that medial portion, really going directly underneath it. And you'll see that when you put that needle into that crevice down deep, you can check it again in long axis to essentially parallel to the tendon fibers. and you can see that you're going to have you're going to have your needle down deep in this area. The goal is to not injure the articular cartilage on top of the talus, but to get it underneath the fab pad. And just FYI, many of these slides are not my own. You'll see them referenced, like for instance, this is a Nisora slide. Let's talk about the ankles, the ligaments of the ankle from the lateral side. So, and I start here because this is like the most commonly injured ligament. The ATFL, the anterior talofibular ligament, is also known as the always tears first ligament. Now, it's not just that it always injures first, but also that if you do have injury, like traumatic bad injury, the ATFL is going to injure first, and then the calcaneofibular ligament typically is going to injure second. The posterior talofibular ligament is not something that people are commonly looking at because it's not only uncommonly being injured, but it's also rather difficult to visualize under ultrasound. That being said, though, we'll show you how to look at that anyways. And if you do get injury to the PTFL, it's going to be because the CFL and the ATFL are already injured, and you essentially have like a fully disrupted ankle. So this arrow is to just sort of remind you that they sort of injure from this anterior to posterior pattern. Okay, here's the ATFL. This is a Bianchi and Martinoli image, but you can image it from this side. It's obviously goes from the talus to the fibula, and so you're going to look at the lateral malleoli and look at where it goes towards the talus. Now, this is one of those ligaments, like many of the ligaments in the foot, that you can test with inversion, eversion, or some other form of stress testing. So you can place your ultrasound probe over there and essentially take the foot and try to stretch it and put it on lax and on tension to get a view for it. But you can see in these two images here, this one on the right obviously is very taut, and the one on the left has lost that normal fibular pattern. It's very thickened. You can find oftentimes where if you have acute injury, you're going to have disruption of the cortical attachment points on the bones as well. Looking at the calcaneofibular ligament, if you have a difficult time finding this ligament, I think the big tip for it is just really look behind the malleoli and look for the the peroneal tendons, the peroneus longus and brevis, and then look deep to it because they overlie the CFL. You want to obviously go in the direction between the calcaneus and the fibula. But that's the secret. Look for that, and also to put the foot into neutral and then invert and evert it and see if it pops up. Obviously, for most of these things, if you have a difficult time identifying them, or if you think you identify pathology, it's important to look at the contralateral side as comparison. This is the posterior talofibular ligament. You'll see in this upper right corner here, it's a small ligament that runs from the posterior aspect of the fibula, and it runs to the lateral tubercle of the talus. You'll notice in this image here that I found this from a paper. There's the medial tubercle, lateral tubercle, and it's just this little short ligament right here. Again, if you really suspected it, it's likely that the other ligaments are already disrupted, and you're probably going to have other advanced imaging done as well. For sake of completeness, there is a ligament between the tibia and the fibula, the anterior tibiofibular ligament, and you can look at this as well. It's a pretty simple one to visualize. Okay, now let's talk about the tendons in the lateral ankle. Okay, so there's primarily two tendons that we're going to be concerned with. It's the peroneus longus, the peroneus brevis. They start up way high, essentially along the lateral border of the proximal fibula. The peroneus brevis will insert at the base of the fifth metatarsal. It's a common area for fracture. It's called a Jones fracture. The longest inserts at the medial, the first metatarsal and the medial cuneiform. Now, one thing that we're going to discuss in a second is there's a superior and inferior perineal retinaculum. These are retinaculum that hold them in place so that they're not flopping around. Now, so the peroneus longus, these are from the ESSR images. The peroneus longus turns into tendon much higher than the peroneus brevis. And so you'll see in this first image, in this A here, this image that I'm pointing at here, we have here where we have one looks very much like a tendon and the other one is still rather muscular. And so it's because the longest is much longer, but it's turns into a tendon much more proximal or superior. And as you trace them both down to the malleoli and the retromalleolar space, you're going to see that they're obviously going to both turn into tendons. We have the longest here. It's going to be on the outside. It traverses a longer path. And so it runs from the outside. The peroneus brevis is on the inside, both adjacent to the fibula. And there is a superior peroneal retinaculum that holds them in place. And you have to be cautious for anisotropy here, but you can trace both of these tendons down to their insertion points. You can trace, I really just focus on the brevis because that's commonplace to find pathology. You can have split tears in the brevis. You can have Jones fractures where you can have disruption at the insertion. I've actually caught this a few times in like soccer players and even adults that had a patient that said they stepped off a curb poorly and they had pain along the lateral side of their foot. It took 2 seconds to find it under ultrasound. So the medial ankle ligaments are a lot more complex. And the big one that people really focus on is the deltoid ligament. And so depending on which way, which book you look at, I think, and there's different categorizations of them. People will say that there's 4 ligaments or there's maybe even 5 ligaments. But for the most part, they're described as being 2 layers. There's a deep component and a superficial component. And again, these are just named after the things that they're attached to. So let's talk about the superficial component because that's really what we visualize and see a lot of times. You have the tibiocalcaneal ligament. Obviously, it goes from the tibia to the calcaneus. And you have the tibial navicular ligament. And then you have the deep component, which is the posterior tibiotalar ligament and the anterior tibiotalar ligament. Most times that people are visualizing these, they kind of fan out, sort of like what I showed you earlier. So they'll start in the back and they'll start finding the first one that they can find back here, which is going to be the deep component, but the posterior tibiotalar ligament, and then they start fanning forward to the front and trying to figure out what is injured. Again, you're going to need a really good ultrasound device to really pick out the details in all these ligaments. This is again from the ESSR. And again, they have it broken down into essentially three portions: tibiotalar ligament in the back, tibiocalcaneal ligament in the middle, and tibionavicular ligament. Again, it obviously helps if you're familiar with the bony structures that they're attached to help figure out where you're looking at. Okay. And I think that's really the secret if you want to visualize these things, is to understand which bones, which bones you're looking at, and identify the ligaments that way. Quickly talk about the spring ligament. This is just for completeness sake. The spring ligament is not really spring. It was identified and called the spring ligament because of the mechanism that they thought that it performed. But there's really 3 of them, and there's the ones that you can visualize the best are really superior medial and the medial plantar calcaneal navicular ligament. Now, all 3 of them are CNL, meaning they attach the calcaneus to the navicular bone. Okay, and so again, if you're familiar with the orientation, if you can figure out where the calcaneus is, you can figure out where the navicular is. It's in front of the talus. You can see the ligaments that span this stretch. Now, the one thing I'll point out here is that the point of the spring ligament really is to prevent the foot from collapsing. If you look at it, it ties this part to this part, and which means it squeezes this together and holds the talus and the rest of the foot up. So it creates this arch here. Okay. Imagine if these were disrupted, it allows this talus to collapse down in between here, and essentially you get a flat foot. And so what does that look like? Well, again, here on the left, we have the calcaneus, we have the navicular. Remember, they're called the calcaneal navicular ligaments, and they overgo the talus attaching the calcaneus to the navicular. It's difficult in this image to see the different slices of it, but you kind of get the gist of it. And again, you should compare side to side. If you have index of suspicion for injury, I would consider getting an MRI as well. Okay. Talking about Tom, Dick, and Harry, these are the big tendons on the medial side. The one So everybody knows Tom, Dick, and Very Nervous Harry. It's tibialis posterior, flexor digitorum. You have an artery surrounded by potentially 2 to 4 venous structures, tibialis posterior nerve, and flexor hallucis. Tibialis posterior is the first big one that you're going to see in this area. And this is what it looks like. So here's the median malleoli. Again, we have tibialis posterior here. We have flexor digitorum, and then we have an artery surrounded by 3 veins. Sometimes it'll look like what people call like a Mickey Mouse sign, where it's just one artery with like 2 veins, meaning it looks like Mickey's like face and his 2 ears. This is just that same image blown up. Here's another cartoon image that shows this. Again, the tibialis posterior tendon, FDL, artery, veins, the tibial nerve, and the FHL. And we do have a flexor retinaculum that overlies this, and that's how you visualize it in this orientation. And it's important to understand that what you're looking at here is also what they call okay, I'm getting ahead of myself, but it's the tarsal tunnel. And you can get neuropathy here with that tendon getting, or excuse me, if there's fluid or tendinopathy or some kind of vascular anomaly here, AVM, whatnot, you can have tarsal tunnel syndrome. I didn't show images of all these tendons traced to their insertion points, but it's just important to be able to follow them in short and long axis to figure out where the pathology is coming from. Be aware that there's something called the knot of Henry. It's an intersection syndrome between the FHL and the flexor digitorum, and that's sort of near the medial side, almost to the bottom of the foot. So tarsal tunnel syndrome, I already described it. It's posterior tibial nerve. It's trapped underneath that flexor retinaculum. Again, you can have edema in this area, tendinopathy, vascularity, et cetera, something that's causing compression on that tibial nerve. Keep in mind that the tibial nerve does split into the medial and lateral plantar nerves. And even that lateral plantar nerve, it gives rise to the Baxter's nerve. And Baxter's nerve is an interesting concept because it's something to be aware of, because a lot of times people will say that they have medial foot pain, and you might confuse it with plantar fasciitis because it's near essentially where the plantar fascia inserts on the anterior calcaneus. And so it's common to have that get mixed up. I'll describe plantar fasciitis a little bit, but there's a phenomenon that's mostly associated with that helps differentiate, and it's called the first step phenomenon. But that you can't hang your hat on that diagnostically. So that's why we move into plantar fascia. People have foot pain. It's worse in the morning with the first few steps. Standing after long sitting is how they might describe it. You can have tenderness a lot of time in the plantar aspect of foot. A lot of times it's going to be most tender near the plantar fascia insertion on the anterior calcaneus, especially on that medial portion. And there's a lot of ways to diagnose this. Ultrasound is one way to do it. You can get an MRI. You can even see it on X-ray. You can get changes in that bone. But I really like ultrasound for this because it's very quick and easy to do. Again, you have multiple slips of it, and it's going to insert here maximally and put a lot of strain there on the medial portion. So this is what happens, and you'll hear this a lot. People will say, "Hey, and unfortunately, it's described like this inaccurately." So people will say, I have foot pain, and they'll order a foot X-ray for one reason or another, and they explain to them that the reason why they think they have foot pain is because they have bone spurs. And the reality is that you see this bone spur down here, right? And this is just a symptom. It's a symptom as opposed to the pathology. And what that means is that, bones can only respond to stress by growing. And so you have this plantar fascia, you have tendon injury, tendinopathy, and it creates an enthesopathy, and where it's been stressing on the bone, pulling on the bone. Now, you might have most pain there, but the reality is that the bone itself is probably not what's painful, as opposed to the structure that's attached to it. And so the bone itself is not really the primary cause of it. It's really just a symptom of the pathology. So let's look at the medial calcaneus again. We have the bone here. You have this nice gentle slope, deep slope rather, as it comes down. We have the plantar fascia as it comes off the bone. So it has this nice morphology. It thins out very quickly. Again, this is what that normal calcaneus might look like. You can see the insertion point right there, and that's the plantar fascia as it inserts there. There's a little bit change in the signal right there, suggesting that there might be some pathology there. You can see it definitely here on this weighted image. And here's it on ultrasound. You see it's a little bit thickened. It's lost that morphology there, where that's the fibular fibers are running forward. Here's probably a better image of it. You notice on this right side, this is what's normal. And on this left side, the insertion point has lost that normal architecture. There's different studies that have looked at this based off of cutoffs for width. I don't necessarily think that measuring is always absolutely necessary. Most ultrasonographers recognize things by pattern recognition, and you see what's normal looking, the normal morphology for something, as opposed to something that's abnormal. Something to be aware of in this area, if you are going to be doing injections, and most people know this, is that there are fat pads here that provide cushioning to the foot. And if you're performing injections with corticosteroids, you really want to not cause fat pad atrophy, because then someone's going to lose the cushion in that foot. And so you want to perform injections in this area if you are going to do them under ultrasound, live guidance, and so that you can avoid that and actually put the injectate where you want it to be. Moving on to the posterior ankle. This is the Achilles tendon. It's the longest, strongest tendon in the entire body. It can absorb a lot of weight, but it has a weak point known as the hypervascular area, approximately somewhere between 2 to 7 centimeters, proximal to the insertion point. And so we have this person, you notice their foot is probably neutral, maybe even a little bit dorsiflexed, right? It's hard for someone to actually maintain this position without dorsiflexing their foot, because the natural position is probably just to sort of hang out like this. The thing about dorsiflexing the foot is that it makes it much easier to lay your probe on it flat without having a little bit of curvature there. And so what you're finding is that you have the calcaneus, you have the fibers of the Achilles tendon. You notice this portion here, that's anisotropy, because the tendon is starting to curve, and it's going to have fibers that will essentially drill down into the bone and connect with the subcortical bone. That being said, though, the normal morphology for this tendon, you'll notice, is for it to come off and very much taper off very quickly as it comes into the myotendinous junction and it meets the soleus and the gastrocnemius. We also have back here a large Kager's fat pad and a little tiny bursa here in this patient, okay? Again, there's that hypovascular region, approximately 2 to 7 centimeters cephalad to the insertion point. There's multiple bursa that are here. I always believe that primary bursitis is rather rare, and it's typically going to be secondary to another issue. And so if you have that subcutaneous calcaneal bursa, you could get that from wearing really tight shoes and have that constant rubbing causing a friction syndrome. There's the retrocalcaneal bursa that's there, essentially right above Kager's fat pad I showed you in the last image. And that I find a lot of times gets filled up with fluid when you have a tendinopathy in the Achilles tendon. So that brings us to this image. This is an MR image. And you notice a couple things here. So number one, there's the arrow sign. Someone's already put an arrow here, and it shows you that, hey, there's fluid here in the bursa. The other thing that you notice, though, is that you have this tendon, the Achilles tendon, as it runs up proximally, and it has an increased T2 signal in these fibers here. Not only does it have that, though, but instead of having that normal morphology where I showed you where it tapers off like a chili pepper quite quickly, it actually bows out and it gets thickened right here. And so we mentioned earlier, before you develop anything else that's worsening of the tendon, one of the earliest signs is just purely thickening of it. Obviously, I'm showing you here that you also have increased fluid signal there. So again, there's that retrocalcaneal bursa, and it can get quite large. If you do want to put steroids into it, I would avoid injecting into the tendon for sure with steroids. You can try to inject into the peritenon space if you're very careful about it. You can consider depositing some of it here to kind of get this to calm down. And sort of like tendon scraping as well. It's been shown that when people have inflammation in this area, this fat pad actually sort of has a tendency to want to adhere to that tendon. So what you can do is you can put a needle through here and inject, essentially hydrodissect it away from the fat pad and get it to move better. And that I've had some success with that in patients as well. Purely injecting, essentially, you could try 5% dextrose, or you can even just use dilute lidocaine and open that all up. So again, these are just different images of that. You notice here in short axis, the Achilles tendon can have portions of it that are injured, like this part here. I can't tell if this is lateral or medial, but you can tell that this portion here has lost that nice compact broomstick on end pattern, whereas this portion still looks relatively intact and normal. And so it's important to evaluate the structure, which is it's a large tendon, and you're going to evaluate it sort of front to back and side to side, make sure you're not missing anything. The cutoffs for a pathologic tendon, besides just looking at the morphology, is that once you're about greater than 8 millimeters, it's not even suspicious. It's probably about a 90+% sensitivity and specificity for tendinopathy. Again, same images, again, Achilles tendon short axis. We have that in short axis there, and you can have, again, a portion of it that is injured, more injured, if you will, than the rest of it, whereas this portion probably looks a little bit more normal, and as well as this one. You notice here that we have a nice gel bridge, so this is the edge of the skin, and so there's gel bridge over here. You can utilize that to look at these types of structures. If you wanted to inject, you can go very quickly and easily underneath it like this and dissect it away. Or if you wanted to go into it with something like PRP, you can specifically target the areas that are injured without going in long axis and sort of going through a bunch of healthy tissue. You can kind of just, fenestrate along those ways. One thing that I've learned is that when I'm injecting into these tendons, number one, it can hurt, but I inject into the pathologic region, and I don't need to get too aggressive, because when you're injecting, it's going to flow along the path of least resistance. And so, if you're trying to get it everywhere, obviously, if you inject into it, it'll flow along those lines, because if it's healthy, it's going to be very painful. It's not going to flow at all. Just another image showing it in long axis, showing where you have on this superficial portion here, it looks like it's much more damaged than the deeper portions. Just the same exact thing, just sort of beating a dead horse. And this is an MR image. It just shows you, though, the things, the other thing is that people will say, I did PRP for something like this, and, why didn't it respond? And you have to understand that the tendons actually have tenocytes. They have TSCs, tenocyte stem cells, and these stem cells can differentiate. The thing is that we can stimulate them in petri dishes to differentiate in a bone. We can get them to differentiate in a tendon, which is what you want. And unfortunately, you can also get them to stimulate, or you can also stimulate them to turn into fat. And when you get to this point where people have these kind of changes, it starts turning into fat, and you get these what they call mucinous changes, like mucoid, like essentially like a snot. And so it loses that structure, it loses its tendon fibrils, it loses all that normal architecture, and then it becomes very difficult. So then if you're at that point of pathology, and then you say, well, I tried PRP or something like that, and the patient didn't really respond, it's because the tissue's not really healthy, and it's sort of the TSCs that were there might have already changed. If you have complete rupture of the Achilles tendon, there's a couple different ways to manage this. You could potentially put them in a plantar boot and hope that the two ends approximate and they just heal. You can also send this patient to a surgeon and have them repair it. There's multiple ways of repairing it, but they can repair it quite quickly. But believe it or not, even for full thickness ruptures, I want to say there's people that are managed non-surgically as well and still actually have good outcomes. All right, I mentioned that. Actually, that one really quickly. There's my website, gcinstitute.org. You can follow me on Instagram if you'd like. I don't know how much time I took. It was 40 minutes. I had like 60 slides. I talked very quickly, but that's the end of my talk. Do you guys have any questions, comments, thoughts?
Great presentation, Doctor. Excellent. Talking about the foot and ankle, which is very difficult to scan. And you did a great presentation. So yeah, we do have a few questions here. Let me just pull them up here. Let's see. First question is, do you scan feet and ankles with a linear or hockey stick transducer?
I think ideally, if you have a hockey stick transducer, it is the best thing for something, foot and ankle and hand. I don't own a hockey stick transducer in my practice, I have one at the hospital. Ideally, that's what you have. If you don't have one, you just do your best, but ideally, if you have it, I think it's certainly going to help, especially because it's got a smaller footprint. And a lot of them are going to go to maybe 18 or 20 megahertz or more, maybe.
Absolutely. Okay, next question is, what is your experience of finding pathology with ultrasound that the MRI might have missed?
So that's a really, really good question. When we send patients to get an MRI, the radiologist may or may not, even it doesn't matter how much detail you write, they may or may not really have an idea of what you're looking for. They certainly can't clinically correlate. You might get a bad report, you might get a good report. The other thing that's really, really interesting about the foot and ankle is that, especially in the foot, so for instance, the MRIs have pre-selected slices, and they may be, you might be lucky, you might have a 3T MR, you might have even higher, but a lot of them might be 1.5 or 1. And the visualization and is not as good. And more so is that the pre-selected cuts may not actually give you the orientation that you want for that ligament. So for instance, something like the spring ligament, if those ligaments are running in one orientation relative to the foot, and it might be diagonal relative to the way the cuts are done. So it's very difficult unless you have the software to actually go in and adjust the axis of the MR. You can't actually, you can't visualize them as well as you think you want to. I like ultrasound a lot because I can, number one, I'm doing it real time. Patient can tell me exactly where they're having issues with. I can put the probe there and really even stress it and see it open up or something like that. And so I really think diagnostic MSK ultrasound for foot and ankles is really, it's really powerful tool. I mean, that's the short answer.
Absolutely. Next question kind of pertains to regenerative medicine. They're asking, is PRP good for the foot and ankle injuries? And do you use ultrasound to inject?
Yeah, I try to use ultrasound to inject for everything, especially soft tissue. I think as opposed to talking about foot and ankle itself, I think when we talk about regenerative medicine, we'd really talk about tendon tissue types. I think there's a lot of good evidence in treating tendons. There's some evidence in treating ligaments. For the most part, the evidence is actually more robust in the upper extremity. The elbow is like the poster child for regenerative medicine. So we have a ton of studies on, common extensor tendinopathy. Rotator cuff, we have some studies. There are people that have looked at the hip and the knee and the ankle. I think probably for reasons of stress and the inability to immobilize. I think when you're treating foot and ankle pathologies, the outcomes are not as robust as in the upper extremity. But do I think that it's a viable treatment option? Absolutely. Because if you look at the orthopedic solutions for like ankle issues, they're not really that great. And even the ankle fusion surgery outcomes are not really that great. And that people have a lot of disability for the rest of their lives. And so I think we should exhaust our non-operative options anytime we can.
Sure, absolutely. A couple more questions here. Can you identify Morton's neuromas with ultrasound?
You absolutely can. So I didn't get into the nerves. I wasn't sure if I was going to finish in time. So typically Morton's neuromas are going to be between the third and fourth or the second and third metatarsals. And what you can do is that you can take that probe. So let's say this is the palmar aspect of my foot, the plantar aspect of my foot. You can take that probe. You can either put it on this side or on either side, and you can squeeze the foot, which is, one of the diagnostic tests for it actually. And a lot of times what you can see is that you can see between the metatarsal heads, you can see that there's the neuroma will almost pop its head out like a turtle sticking its head out of its shell like this, and then it'll pop back in. And then when you squeeze it along the other aspects and look for it, you won't pick that up. I don't know if you have any other tips for that, Mark. For picking up a multitrauma.
Yeah, that's exactly what we do too. You do squeeze the foot and it does pop up. So yeah, that's the only technique I've known to use, and it works. Okay, excellent. Next question. It is known that the ATFL has two bundles, superior and inferior. In your experience, have you been able to describe isolated tears of those bundles? Then part of that last question here, would it be clinically relevant to report in that manner?
You know, so let me rephrase that in a way that might make sense to someone. I think a lot of times when we're identifying, so for instance, if you're for a physician, a lot of times when they're first starting with ultrasound, it's actually not even, it's too difficult to identify diagnostic structures. It's very challenging. The learning curve is very steep. What's probably easier for me to just tell you is, hey, here, you know, behind the knee, you're going to find an artery and a nerve right above it. If you want to do a sciatic nerve block, just put your needle here. You know what I mean? So what I'm trying to say is that if you can at least, you know, whether or not you can tell if it's the anterior bundle and the posterior bundle and all the stuff, if you can identify there in that area that you can tell that the normal ligament looks like this, and that does not look like normal ligament, and you want to treat it with like PRP or something like that, as long as you can identify what normal looks like and it's abnormal, I think that's really the crux of it. Whether or not you can, for instance, like if we want to look into the knee, and the ACL has two bundles, and you can, it's really difficult to see that stuff under ultrasound. If you can even pick it up at all, I think just being able to get your needle there from an interventional standpoint is just the gist of it. So meaning it's nice if you can see it, if you have the resolution and the body habitus. I don't think it's the be all end all, if that makes sense. Right? Meaning like if I showed you a tendon and Mark, if I showed you a tendon, I didn't label it, and I said, you know, you see this thickening, you see these voids and these calcifications, you would automatically say there's something wrong with that, even if I didn't tell you, or even if you couldn't tell which tendon that was. Does that make sense what I'm saying?
That does make sense.
Yeah.
Yes. Okay, last question we have for the evening. Can you diagnose gout with ultrasound? If so, what does it look like?
That's a great question. You can diagnose gout, and that's not really the type of patient that I see a lot. I know that we can see different types of crystals, but Mark, can you chime in? Because that's really not my expertise.
Yeah, when we look for gout, we do look for the crystals. They will be very hyperechoic. They will also have fluid around it as well. Then we also turn power Doppler on. So with those three things, you can really determine if it's gout or not. Then they will do a biopsy of it and confirm it through lab results.
Sounds good. Yeah. I know that you can, I mean, I've seen the images of it in books, and I know that you can also have like hyperechoic speckles within the articular cartilage with different types. It's like the calcium deposits and things like that. To be frank with you, I'm not 100% sure, but I know that you definitely can diagnose it with that. And you would still, like you said, you would still have to confirm it with aspiration and sending it to get analyzed.
Absolutely. One difference with gout and the other crystals is because gout will have a lot more hyperechoic crystals in there. So instead of other pathology, so that's one way to quickly look at it until we do the biopsy.
Awesome.
Well, Dr. Chang, I appreciate all your time this evening. Great presentation on the foot and ankle. I'm going to turn it back over to George. After you.
Oh, well, I'm good. Thank you all for everything. And Mark, it's good to see your face again. And I feel like you never age. You've never aged ever since I've met you. And for those of you who don't know, we go back, 7-8 years. And I just saw you like 3-4 weeks ago. And just so you know, everybody loved you. So thank you for coming out that time to that course.
Thank you so much. My pleasure. Frank.
Okay. So Dr. George Chen, on behalf of Wisonic Medical, thanks for your excellent presentation. And I think the anatomic pictures and ultrasound pictures inside your PowerPoint slides are enlightening. We would like to cooperate with you for more webinars or other activities in the future.
That sounds wonderful, Frank. Thank you so much for everything.
Yes, and Mark, thanks a lot for your efforts again. And I think you already helped ask the very good questions, and we can know more valuable knowledge. Thank you.
You're very welcome. Have a good evening.
Thank you. You too. Take care. Bye-bye.
Yes. And everyone in the broadcasting room, thanks for your watching today. I believe you must have got a lot of inspiration, and welcome you to join our webinar on next Friday. Dr. Brandon Tarzia will present the 7th and the last webinar with topic on ultrasound in MSK practice knee. So let's stay tuned. So good night, Dr. George Chen and Mark Kessler. Let's stay tuned. Let's keep in touch.
Thank you. Take care, everyone. Bye-bye.
Take care. Bye-bye.